Stay connected. Make sure you hit the subscribe button. Greetings, Tim Bennett here from the Cortland Voice. I'm here with Dr. Tran. She is from Cayuga Medical Center. Doctor, how are you?
Doing well, thank you. Thanks for the opportunity.
Thank you. Today we're speaking on women's health. Tell us, but before we get into fully diving into women's health, let's hear about you. Like, where are you from? Where'd you go to college? Tell us about that.
Sure. So I am a fellowship-trained breast surgeon. I also was a general surgeon before that. And then before that, I was a biomedical engineer.
Awesome. And where are you from? Are you from Ithaca area or out of state?
I trained for a fellowship in Columbus, Ohio. I did my general surgery training in New York City area and surrounding area. And I did my college in California.
Awesome. Okay. Well, welcome to Ithaca.
Thank you.
Ithaca, Cortland, I should say. So why is women's health so important to you? I know that, that's what you studied in college, but why is it so important to you? Why is it your heart?
I think women's health can still, while we've come a very long way in women's health, there's still a lot of progress to be made. I think women are a very important part of our society and our community, and that there's still a lot of work to be done in terms of advocating for access to care and also bridging the accessibility and disparity in care.
Agreed. So why do you feel that it's so important to get your mammogram, and how often should someone get it?
Yeah, there have been quite several studies that has been done. Mammograms are the best available tools that we know right now to help with screening and diagnosing breast cancer, and early diagnosis and screening is very important for prognosis. And also the recommendations from the Surgical and Medical Society, the recommendations from the Surgical and Radiology Society recommends that we start our yearly annual mammogram at age 40 for the average risk person, and earlier if we are of higher risk.
Now, going off of that, how do you know if you're more at risk, know?
Yeah, so higher risk patients tend to have a strong family history or have a genetic predisposition. And also, in addition to that, other factors such as dense breast can sometimes put patients at a higher risk.
Understood. But should people only with dense breast get checked, or like what are your thoughts on that? Like who should get a mammogram?
So women of average risk at age 40 can start getting their mammogram. In fact, we're actually learning that maybe a baseline at age 35 may also be helpful as well, because it's not just about a snapshot, it's also about trend over time. And then women with higher risk based on their genetic predisposition and or family history and or other factors that can also get earlier screenings as well.
That makes sense. So if you're more at risk, you should really go younger than the 40 at around 35 or so. Okay.
Yep, and maybe even younger than that, depending on the youngest relative of breast cancer. We recommend that for first degree relative 10 years earlier. And so sometimes that falls into the 20s.
I see. So sorry.
And with available tools that we have for imaging, the mammogram is the standard for screening, but there's also supplementary modalities such as an ultrasound or an MRI.
Okay. So I see how that would fall under the preventative care and things like that. I get it. How much does genetics dictate with breast issues? I know that you're saying family, like how much of it, is it more nature? Is it nurture? What is it?
Yeah, it's a mix of both. So if we take a pie of 100 breast cancer patients, as of now, about 5 to 10% of that is from known genetic risk, meaning that you have a gene and we can test for it. And about 15 to 20% is from strong family history, but we still haven't found the genes yet because we're still learning about genetics. So that means approximately about 70 to 80% of breast cancer is what we call idiopathic, meaning that it happens to the average risk person. And the average risk person is about 10 to 12% lifetime risk of getting breast cancer. So 1 in 8 women can be affected by breast cancer, and that is a lot.
Oh, it is. Should high risk breast cancer patients consider having a mastectomy as precaution?
I think that is a really personal choice. I think the idea is to really talk to their different various providers and specialists to see if that choice is right for them. I think high risk has a variation from strong family history to either strong personal history or genetic predisposition. And risk to be considered high risk, you have to be at above the 20% threshold. And so that means that between 20% to 100% is a wide range. And so while a prophylactic mastectomy or bilateral prophylactic mastectomies may be beneficial for some, it is not necessarily right for all, and is also a very personal choice. And so that's something that through shared decision making with their providers and their specialist, patient can come to whether or not that's the right for them.
Tell us about oncoplastic surgery and, when a patient should consider it.
Yep, I think oncoplastic is twofold. Oncoplastic can mean the reconstruction aspect for that you work with plastic surgery with for various implants or tissue transfer and such. Oncoplastic can also mean that at the time of their original surgery, things that could be done to maintain as best as possible the shape, even though the sizes would change.
Okay. And is benign breast cancer, or excuse me, is benign breast disease a cause for concern?
Benign breast disease is something that can be followed and it's very rare that they turn into cancer, but however, they may put a patient at higher risk depending on what it is. And so there is a spectrum from benign to high risk lesions to cancer.
Okay. Well, at the Cayuga Medical Center, I know that you have access to a lot. What technology do you have access to, whether it be your Cortland office, Ithaca office, wherever?
Yep. Throughout our health systems, we have up-to-date 3D mammography, along with ultrasound technology and MRI technology, all of which are utilized to help diagnose and screen for breast cancer.
Do you work with any other specialists or anyone for maybe like a special case or for someone with invasive breast cancer?
Yep. For all of our breast cancer cases, we work in a multidisciplinary team. I work as the fellowship trained breast surgeon, but I also work with the medical oncology team, the radiation oncology team, along with the radiologist and pathologist and the nurse navigation team.
And what do you say to people who are hesitant on getting a checkup?
I think that getting a checkup is very important. Screening mammograms have been shown to save lives, and it also changes the course of someone's life trajectory. And so I think if they have any hesitation to talk to their providers and be educated on that, it is a very important tool and progressive tool that we have.
For those who have, medical healthcare benefits, is it considered like something that would just be covered on there?
Generally, the imaging are covered. However, it's also good to check with their healthcare providers or insurance carriers. And there are also programs for people who don't have insurance that can give them their mammograms and such. And so that's also worth exploring.
Beautiful. Is there any other things that you would like to say to the community?
I think that it's important for people to understand what are available to help take care of them, and for them to talk to their primary care providers about the appropriate screening exams for breast cancer. It is Breast Cancer Awareness Month, and 1 in 8 women have breast cancer. That means that every one of us at some point in time will know someone, and that early screenings and detection help save lives.
Okay. Well, once again, Dr. Huynh, We thank you for joining us at the Cortland Voice, and to everyone watching, have a great day. God bless.
Thank you. Appreciate it.
Thank you. Stay connected. Make sure you hit the subscribe button.